This is Dr. Aditya Sibi Chakravarti from Dr. Talks. Today we will be starting nephrology session. This will be the first of the many videos. Today we will start with chronic kidney disease. So what is chronic kidney disease? Chronic kidney disease literally means there is renal dysfunction. Because of the renal dysfunction, there will be accumulation of nitrogenous waste products in the body, and there will be problem with the fluid and electrolyte balance, and there will also be other renal functions will also be destroyed. This is what is called as chronic kidney disease. So what are the two important determinants of chronic kidney disease? The two main important determinants of chronic kidney disease include the urine creatinine excretion, urine albumin excretion, and the serum creatinine value. The serum creatinine and urine albumin excretion will mainly determine the CKD. So what is the pathophysiology? What happens in chronic kidney disease? In chronic kidney disease, there will be an initiating event, a first event. This can be an insult, this can be a congenitally underdeveloped kidney, or a toxin mediated injury to the tubular interstitium, or it can be because of immune complex deposition injuring the glomerulus. There will be an initiating event. After this initiating event, the kidney goes for compensatory hypertrophy and hyperplasia. This hypertrophy and hyperplasia will maintain the GFR in the short period of time. Long term, this will be maldeveloped, this will go for maldevelopment, and there will be development of intraglomerular hypertension. Intraglomerular hypertension as a consequence, there will be glomerular injury, finally it will go for glomerular sclerosis. If it's a tubular injury, then they will go for tubular atrophy. If it is mainly an interstitial problem, it will go for interstitial fibrosis. Overall, there is a decrease in the the kidney goes for decrease in nephron number. There will be a glomerular sclerosis if the glomerulus is the main site of involvement. There will be tubular atrophy and interstitial fibrosis if the tubular interstitial is the main site of involvement. So what is CKD? Decrease in number of nephrons and decrease in size of the kidney. That is what is called as CKD. So what are the risk factors for CKD? First, we will deal with the genetic risk factor. The most important genetic risk factor for CKD will be a polycystic kidney disease. That is the most common risk factor. The second most common, the other risk factors include mutation of APOL gene. This is associated with increased incidence of CKD in West African population. Then what are the acquired risk factors? Who are all more prone for developing a CKD? A small for gestational age baby, a patient who has had a history of childhood obesity, a patient with diabetes mellitus, hypertension, some structural abnormality of the urinary tract, some glomerular nephritis, or a chronic glomerular disease. These patients are at high risk of developing CKD. So what are the causes of CKD? The five most important causes for CKD will be the first most common is the diabetic nephropathy. Diabetic nephropathy has got a high rate of progression to very rapid progression to CKD because it has got a high drop in GFR. Estimation of 8 to 7 to 8 ml of GFR will be lost per year in diabetic nephropathy. Then there are other group includes chronic glomerular nephritis, hypertensive nephropathy, chronic tubular interstitial disease, and the autosomal dominant polycystic kidney disease. These are the five major causes of chronic kidney disease. So how do you stage the chronic kidney disease? We basically stage the chronic kidney disease based on the eGFR calculation. We calculate the estimated GFR based on the serum creatinine value and other parameters like age, sex, by using either Cockcroft-Gault equation or a MDRD equation or a CKD-EPA equation. All these equations can be derived. So how do you stage? So stage 1 means the eGFR is more than 90. Stage 2 is 60 to 90 ml per minute per meter square. Stage 3 is 30 to 60 ml per minute per meter square. Stage 4 is 15 to 30 ml per meter square, and stage 5 is less than 15 ml per minute per meter square. So this is the grading of CKD. And also you base the grading all based on A1, A2, A3 by the degree of albuminuria. Mild albuminuria is less than 30 mg per gram. Moderate means 30 to 300 mg per gram. Severe means more than 300 mg per gram of albuminuria. So that is the staging. Based on the staging, stage 1 and stage 2 diabetic CKD patients won't have any much clinical manifestation. It will be predominantly you take an creatinine, you estimate the eGFR, you can think it as CKD. Other than that, the patient won't have any signs and symptoms of CKD. In stage 3, stage 4, there is the beginning of all the symptoms. We deal with fluid electrolyte balance, bone mineral problem, cardiovascular problem, anemia, a wide plethora of problems starts in stage 3 of chronic kidney disease. The stage 5 CKD is also called as the end-stage renal disease, is the one that carries the worst prognosis and which has got very significant and severe manifestations. So, what are the rate of falling of GFR? Normally, the GFR will begin to increase up to 30 years of age where it reaches the peak. After 30, the GFR falls by approximately 1 ml per minute per year for a period of, so by a 70-year patient will have a normal GFR of only 50 or 60 ml per minute, 50 or 60 ml. This is the difference between men and women. Women have got a less GFR than men. Generally, women if it's more than 80 years will have a GFR of usually less than 50 ml per minute only. So this is the rate of fall of GFR. So diabetic nephropathy, hypertensive nephropathy, chronic glomerulonephritis will all have high rate of fall of GFR in more than 1 ml, 3 ml, 5 ml. That high level of fall in GFR will be seen in other these conditions. So first we will be dealing with the symptom complex of CKD. First one will be the water metabolism and hyponatremia. So in a chronic kidney disease, as we have already mentioned, there will be decrease in urine output. There will be decrease in sodium and urine excretion. So there will be retention of sodium. This retention of sodium will cause water retention. This will increase the extracellular fluid volume. So increased extracellular fluid volume can manifest as peripheral edema. It can manifest as raised intravascular edema. If it manifests, can result as pulmonary edema, or the patient can have decreased urine output. Hyponatremia in CKD is usually very mild. His hyponatremia will respond to even just fluid restriction alone, that will be fine. So this water hyperolemia, you can manage it with fluid restriction, salt restriction, diuretics. Diuretics in the form of loop diuretics, Lasix can be given, loop diuretics, or go for thiazide diuretics can also be given. Combination of Lasix plus metolazone can be used in refractory cases. Worst case scenario, you will go for dialysis. So hyperkalemia. CKD is notorious to cause hyperkalemia. So why does hyperkalemia occur in CKD? This is because the rate of fall in GFR will not be parallel to the rate of fall in potassium. This is because the potassium excretion will occur in the distal convoluted tubule and is under the control of aldosterone. It is a unique mechanism. And so in CKD patients, there will be defective potassium secretion leading to potassium retention, leading to hyperkalemia. So which condition develop early and severe rise in potassium? In conditions like diabetic nephropathy, sickle cell nephropathy, and obstructive uropathies, where the problem will be in the distal convoluted tubule. If there is an involvement of distal convoluted tubule, there will be early hyperkalemia and severe hyperkalemia. So what are the risk factors for developing hyperkalemia? If you go for hemolysis, rhabdomyolysis, packed cell transfusion, the old packed cell transfusion, or drugs like AC inhibitors, ARBs, potassium sparing diuretic in the form of spironolactone, eplerenone, all these drugs will increase the risk of hyperkalemia. So how do you treat hyperkalemia? Treatment of hyperkalemia is hyperkalemia is a medical emergency. You diagnose based on the ECG findings. ECG can have VT or VF will be picked up. Then you will manage with, first you have to give calcium carbonate, calcium gluconate, 1 gram. It should be given over 10% over 10 minutes to myocardial stabilizing. Then other measures you can do will be 25% dextrose can be added to 10 units of regular insulin can be added to 25% dextrose and can be infused over 1 hour. That can be done. Then you can go for inhaled high dose salbutamol nebulization, that can be done. Then you can go for sodium polystyrene sulfonate. It is a potassium binding resin that will eliminate the potassium, and you should go for a potassium restriction, dietary potassium restriction, and avoid the potassium sparing diuretics and other potassium increasing drugs like AC inhibitors, ARBs. They should be done. If nothing works, you have to go for dialysis. So what is metabolic acidosis? Metabolic acidosis, this is because chronic in a CKD patient, the kidneys cannot develop enough amount of ammonia, and also because of the hyperkalemia, the production of ammonia will also be very low. So low ammonia will, and also there will be accumulation of this this anions will be accumulated in the body. So in the initial stages, the patient will have a stage normal anion gap metabolic acidosis. In later stages, because of the accumulation of all inorganic ions, the patient will go for high anion gap metabolic acidosis, hyperchloremic, hyperkalemic, high anion gap metabolic acidosis in the later stages. In early stages, we will have normal anion gap metabolic acidosis. So when do you treat this metabolic acidosis? When the pH is less than 7.1, it is very variable. The guidelines vary. You can go for soda bicarbonate treatment. Tablet can be given 650 mg TDS, or an IV correction if the pH is less than 7.1 and if the bicarb is less than 15, you can go for IV correction. Then now we will go for bone mineral diseases. So what are the bone mineral diseases? First we will be dealing with the high bone turnover. What does high bone turnover means? High bone turnover means there will be increase in parathyroid hormone. So how does parathyroid hormone increases? We will see. In CKD patient, there will be a decrease in the glomerular filtration rate. Due to the decrease in glomerular filtration rate, there will be phosphate retention. This retained phosphate will increase the FGF23 release and from the mature osteocyte, and it will also increase the PTH release from the parathyroid gland. This FGF23 will inhibit the 1-alpha hydroxylase enzyme, thereby decreasing the vitamin D production. So decreased amount of vitamin D will decrease the calcium and phosphorus absorption from the intestine and it will also increase the PTH production from the parathyroid gland. Summing up, the patient will have an increase in parathyroid hormone, there will be increase in phosphorus level, there will be decrease in calcium level and decrease in vitamin D level. So for parathyroid, phosphorus increase, calcium, vitamin D decrease. This is what is called as high bone turnover. What happens because of high parathyroid hormone? There will be increased bone resorption and increased bone mineralization, and there will be bone marrow fibrosis in the early stages. In late stages, the patient can for bone cyst formation. Sometimes there can be hemorrhage into this bone cyst. They can form what is called as Brown's tumor. This finding is called as the osteoitis fibrosa cystica. So this is the high bone turnover. Patient can present with high bone pain, pathological fracture, bone marrow fibrosis, and there will be resistance to the given erythropoietin. So what is low bone turnover? Low bone turnover means there will be low parathyroid hormone. How can the parathyroid hormone be low? The parathyroid hormone has to be suppressed. What suppresses the parathyroid hormone? The calcium supplementation, the calcium carbonate which you give, or the vitamin D supplementation which you give, or because of the presence of calcium in other dialysis preparations, they can cause low bone turnover disease. Then other group will be the osteomalacia. Osteomalacia literally means there is a defective function of vitamin D, the calcitriol function will be defective and the amount will also be defective. This is what is called as the osteomalacia. So calcified axis. So what is this calcified axis? There is occlusion of dermal vessels. The dermal vessel occludes, and this occlusion is because of subcutaneous calcification. Subcutaneous calcification is because of hyperphosphatemia and hypercalcemia. So because of the occlusion of the subcutaneous vessels, there will be levator reticularis, there will be areas of ulcers, levator reticularis initially, then the patient can develop extensive skin ulceration. So extensive skin ulceration because of subcutaneous calcification as a result of hyperparathyroidism, or it can be because of warfarin. If you are given warfarin, there will be decreased production of matrix GLA proteins that can also cause this problem. So what are the vascular complications? Vascular complications literally means there will be change in the endothelial cells. In hyperphosphatemia, the endothelial cells will be converted into myofibroblast. This osteoblast. This osteoblast will trap calcium and will result in endothelial calcification. The parathyroid hormone can cause medial calcification, and the hyperphosphatemia can cause endothelial calcification. This endothelial calcification can affect the coronary arteries, it can affect the heart valves, it can be associated with hypercalcemia. So how do you treat high bone turnover? There should be either there will be increase in PTH or increase in phosphorus. The increase in phosphorus can be managed with phosphorus restriction or phosphate binders. Phosphate binders in the form of calcium carbonate or in the form of cevilamide and lanthanum. This can be given. In worst case scenario, you will go for dialysis. Hyperparathyroidism, this can be managed by either vitamin D, calcitriol is an antagonist for PTH. So calcitriol can be given, or other calcitriol mimics like pericalcitor or doxorcalciferol, they can also be tried. So this in low bone turnover, you just have to stop the calcium supplementations and you have to maintain a target PTH between 150 to 200 in CKD patients. So what are the cardiovascular problems? First, pericardium. Uremia can involve the pericardium significantly. There can be involvement of acute pericarditis in the form of chest pain with a respiratory variation. The patient can have pleural pericardial rub. The patient can have findings of ECG showing ST uptake, diffuse ST uptake or PR depression. This acute pericarditis can develop into a pericardial effusion, develop a pericardial tamponade as a sequence of findings. This can be seen acute pericarditis. So you have to treat these patients with dialysis. Uremic pericarditis is an absolute indication for dialysis. The other thing you can do, you can forward for NS, that is usually will be hemorrhagic fluid within the pericardium. You have to go for non-heparin dialysis in such patients. So ischemic heart disease. There is increased prevalence of ischemic heart disease in CKD patients. How? Because of 2 points. One, the traditional risk factors, diabetes, hypertension, hyperhomocystinemia, dyslipidemia, all these things. And the CKD related risk factors, namely hyperparathyroidism, hyperphosphatemia, dyslipidemia, the unique form of dyslipidemia, and this on the extensive systemic inflammation. This will increase the risk of accelerated atherosclerosis, and they can go for increased chance of ACS, and these patients can go for congestive cardiac failure. And it is one of the most common cause of death in a CKD patient. So hypertension. Hypertension can be both the cause as well as the effect of CKD patient. Hypertension can cause left ventricular hypertrophy, it can cause diastolic dysfunction of the heart, it can cause acute LV failure. Everything can occur as a result of hypertension. Hypertension should be managed. You have to give a BP target of lower BP target, less than 140/90 or less than 130/80. It should not be 120/80, it should be 140/90 or 130/80, depending on the guidelines. Various guidelines give various value. It is better to be less than 140/90. So what are the drugs you can go for hypertensive control? AC inhibitors and ARBs, they can be given. If they are not tolerated, you can try diuretics, Lasix, or the thiazide diuretics can be tried. If they are not working, you can go for CCBs. The verapamiral delsam can also be given. And CCF, the congestive cardiac failure can be because of uremia, not necessarily because of volume overload, it can be because of uremia. This uremia will increase the can cause endothelial dysfunction in the pulmonary capillaries, and it can lead to pulmonary edema even with a normal left atrial pressure. That is called as the low pressure pulmonary edema. This responds to dialysis. So anemia and CKD. Hemoglobin of value less than 10 gram per deciliter is called as anemia and CKD. Why the patient develops anemia and CKD? That is because of either anemia of chronic inflammation. It can be because of decrease in erythropoietin production. It can be iron deficiency, folic acid deficiency, B12 deficiency, any reason, or it can be because of uremic blood loss leading to hypovolemia and then going for anemia. It can be because of any of this reason. But the unique finding with CKD anemia is that you have to replace for treatment, you have to replace both erythropoietin and iron. Iron and erythropoietin both should be replaced. If the bone marrow iron content is very low, you have to go for iron replacement. The transferrin saturation is less than 30%, or if the patient is having low ferritin levels, you have to go for oral iron or an IV iron preparation. Oral iron can cause gastritis. Uremia will also cause gastritis, so oral iron will not be preferred. Go for IV iron corrections. Ferrous sulfate can be given. Ferrous sulfate 100 mg 10 doses can be given. 1 gram of iron should be replaced. Ferrous sulfate 100 mg 10 dose can be given. Iron dextran 1 gram infusion can be given. Or ferric carboxy maltose, or ferric isomaltose, they can also be given. And you have to go for erythropoietin replacement, either an erythropoietin or a darbepoietin or epoietin alpha. Anything of the three erythropoietin can be given. Supplementation of erythropoietin can cause erythrocytosis that can worsen the MI or a stroke can occur with high dose of erythropoietin. So CNS manifestation. So what is peripheral neuropathy? Peripheral neuropathy, you will have a lower limb predominant distal sensory type of peripheral neuropathy, and the presence of peripheral neuropathy in a CKD patient to take the patient, it is an indication for dialysis. The restless leg syndrome, the patient can have an irresistible desire to move about in the bed. It can be a manifestation that can occur before even uremia, and it is very notorious to treatment. The other neuromuscular irritability you can have refractory hiccups. The patient can develop respiratory failure, asterixis, myoclonus, seizures, coma, anything of these features can be seen. The other CNS manifestations includes lack of concentration, lack of memory, lack of focus, or memory loss. These things can be seen. So what are the bleeding? Why does bleeding occurs? Why does thrombosis occurs in CKD patients? Uremia can cause platelet dysfunction, and also there is decrease in the platelet factor 3, and there is defective adhesion, aggregation, and platelet plug formation. So the patient can have uremic bleeding in the form of petechiae, purpurae, menorrhagia, bruises, post-surgical bleeding, anything can be happened. Thrombosis can occur in CKD patient because of increased, usually in the glomerulonephritis, increased urinary loss of proteins, and subsequently there will be increased and the anti-clotting factors and increased production of procoagulant factors can cause clotting abnormality. So another important point with anticoagulation is that if a CKD patient is having atrial fibrillation, we can go for either warfarin or a heparin. Low molecular weight heparin and other newer type of anticoagulants are usually not prescribed because they require dose monitoring or dose adjustment for renal failure. So GAD manifestation, simple. They can have gastritis, abdominal pain, nausea, vomiting, constipation as a result of calcium or iron tablets. The dermatological manifestation, there will be severe refractory pruritus because of the deposition of pigmentary urochromes in the subcutaneous tissue. This will be even refractory to dialysis treatment. And another is a nephrogenic systemic fibrosis. A CKD patient, if EGFR is less than 30 ml per minute, if the patient is giving dialysis with gadolinium contrast, this patient will develop diffuse subcutaneous inflammation of the arms and legs. It is a very devastating condition. This can be protected by not giving gadolinium in CKD patients, or once you give the gadolinium, you take the MRI and you have to quickly take the patient for dialysis post MRI, even if the patient is not taking dialysis. So then the endocrine manifestation, first diabetes mellitus. CKD, the T off of insulin is usually increased in CKD patients because the renal metabolism is decreased and the renal contribution to gluconeogenesis is also decreased, so they are more prone for developing hypoglycemia. So how do you manage diabetes? Insulin doses should be decreased in a CKD patient as the patient worsens, and secondly, you should avoid drugs like metformin and glycosides, and those drugs can be reduced, but you can go for gliptins. Half the dose of gliptins can be reduced, dose adjustment of teneligliptin. Those drugs can be given at lower dose, or SGLT2 inhibitors can be given. What happens in men? There will be estrogen deficiency, the testosterone deficiency. Because of testosterone deficiency, male are at high chance of erectile dysfunction. They can also go in for poor sexual maturation. Female are a high risk of developing, they can develop recurrent menstrual problems, recurrent pregnancy loss. They can go for recurrent fetal loss. And the term delivery will be very difficult in patient with CKD and pregnancy. Dyslipidemia because of increase in the amount of oxidized LDL and increase in LDL. So they can go for the chance of atherosclerosis. So how do you diagnose? You approach to a patient. First, you have to go for the cause of any history of diabetes, hypertension, any history of renal colic, renal problems, any abnormal urine routine, and any abnormal structural renal pathology, anything, those history should be taken. And history of uremia, uremic chest pain, uremic gastritis, uremic weight loss. If the patient is having, go for uremic altered sensorium, everything should be picked up. Family history of any ENT abnormalities, think of Alport syndrome or cystinosis, or a family history of any other renal problems requiring transplant, that should be taken. And signs, predominantly hypertension and hypertension mediated end organ damage. You have to go for fundus for any hypertension or diabetic retinopathy if it's present. You have to evaluate for peripheral edema, go for peripheral neuropathy findings. Everything should be picked up. So lab workup, first the anemia workup. We know we have already discussed anemia, so we would go for hemoglobin, serum B12, folic acid, all these levels, ferritin levels should be taken. Then bone mineral metabolism, you have to measure the calcium, vitamin D, PTH and phosphorus. These four measurements should be given. If you consider serial RFT monitoring, urea creatinine, say if the patient is having a creat of 4.4, it doesn't mean the patient is having CKD. You have to either, if you have a previous creat record, which should also be 4, you should basically serial monitoring of RFT is done to differentiate AKI from CKD. So you have to go for free serial RFT monitoring. And 24 hours urinary protein, if it's more than 300 milligram per gram, you have to go for AC inhibitors should be given. If the multiple myeloma, if you suspect multiple myeloma, or a 50-year-old male with multiple lytic lesions, anemia, raised calcium, and then with the renal failure symptoms, you can go for serum protein and immune electrophoresis. So ultrasound. What does ultrasound show in CKD patients? Ultrasound can show, first one, there will be bilaterally shrunken kidneys. That is diagnostic of CKD unless proven otherwise. Then the patient can have a corticomedullary, the cortical hyperacousia will be lost, the corticomedullary differentiation will be lost. That is second point. Then third one, there will be any asymmetry in kidney development. Asymmetric kidneys, they could be picked up, or the number of kidneys, the position of kidneys, everything can be picked up in ultrasound. If the patient is having asymmetric kidney and if you suspect vascular disease, you can go for renal Doppler. Renal Doppler or arterial and venous Doppler can be done to identify any vascular obstructive lesions. If you suspect reflex nephropathy, if the patient is having in the childhood, he has got multiple urinary tract infection, the ultrasound shows a unilateral shrunken kidney with polar calcification, and to go for mixture-in cystoerythrogram. So when do you go for biopsy? Biopsy in a CKD patient, established CKD patient, is useless, because you know that the kidney is completely fibrosed and there is nothing you can pick up by the diagnosis. And it's a risky procedure. You can have bleeding because of biopsy. Secondly, the yield of biopsy is very poor. You will only be seeing fibrous kidney. There won't be much histopathological significance. You can have glomerulus will go for sclerosis, the tubules will go for atrophy, the interstitium will be predominantly fibrosed. That is the finding you can develop in biopsy. And active urinary tract infection or active cancer or uncontrolled bleeding all are contraindication for biopsies. So how do you manage? The general management of the complication. You have to go for phosphate restriction. You have to go for phosphate restriction less than 1 gram per day, potassium restriction less than 60 milliequals per day, and you have to go for potassium and calcium restrictions should be taken. If the hypertension patient is hypertensive, you have to treat with AC inhibitors, ARBs. There are diuretics or diuretics can be given. Target BP is less than 130/80, and if the patient is having high bone turnover, you can go for phosphate restriction, phosphate binders or dialysis. Or you can go for vitamin D supplementation, calcitriol, pericalcitrol, doxorubicin, these drugs can be given. Then how do you reduce the intraglomerular hypertension? This intraglomerular hypertension is responsible for proteinuria. This intraglomerular hypertension can be reduced by using an AC inhibitor and ARB. This AC inhibitor and ARB will cause efferent vasodilatation. This will decrease the intraglomerular pressure and they can reduce the proteinuria. If the AC ARBs are not effective, you can try CCBs, either verapamil or diltiazem can be given. So dose adjustments. All the drugs should be reduced or either it should be avoided based on the creatinine clearance of the patient. You have to measure the creatinine clearance of the patient, and based on that creatinine clearance, either it is a 25 or 50, only for that creatinine clearance you should administer the drugs. Majority of the antibiotics which we administer, the nephrotoxic antibiotics should be avoided, and even other antibiotics should be given at a reduced dose. So it is important to know the creatinine clearance. Then indication for renal replacement therapy. When will you go for dialysis? If a patient of CKD, if he has got refractory hyperolemia, refractory hyperkalemia, refractory metabolic acidosis, if the patient is going for any symptoms of uremia, you have to take the patient for dialysis. By the term refractory, means they are not amenable to treatment with any drugs. You have to take the patient for dialysis. So transplant. What is the importance of transplant? You can just dialyze the patient and go. What is the need for transplant? only a kidney can only replace kidney can redo all the works of a original kidney. Yeah, this dialysis will just replace the filtration function of kidney. The other secretory functions, other metabolic functions, endocrine functions, everything will not be replaced by dialysis. So renal transplantation is the treatment of choice, and it should be done if possible. So this sums up my discussion on chronic kidney disease. I hope you like the discussion. If you like the discussion, I would like you to subscribe to my channel, share it with all your friends. They will also be benefiting from this discussion. Like, comment and share with your friends. Thank you.